confuses me. But when we're back on Thursday, I'll do a Kahoot and we'll have some more fun. 50 people, 50 people. So we're missing what, 21? My dogs are like, oh, you're laying on the couch. I like it when you sit on the couch. We can lay right on you. This is nice. Especially on your heating blanket. Waiting room 2. Somebody's almost tardy for the party. Always keep thinking, what if someone's having trouble getting on? So I'll wait a few more seconds. That way they have a chance. Ah, someone did closed captioning. Smart. Welcome, Maggie. They must be more confident than us because what, about an hour ago, we're like, you should fire this thing up so we can know that we're doing it. And thank goodness we did, because I found I had the wrong PowerPoint. So if you're missing the PowerPoint to this class, it is posted under announcements. And I'll make sure Thursdays is the right one too. It said PowerPoint there. I changed it off last fall and I just assumed it carried it through, but it did not. It went back to the original one from a year ago. So I guess 53.
I have a question while we're waiting.
Yeah.
So I noticed that you guys are putting the study guides for, certain parts of the lecture. Are those just from the study guide book itself that they sell for the maternity book?
They do not. What we ask for you to do is to look at the objectives for the class. That is where the test questions come from, is from the list of objectives. We put the study guides on there. If it's a topic that you're struggling with, you probably should go ahead and do them if you're struggling. If you've got the material and you don't have time, I can't tell you that it's gonna be like, oh my gosh, this is critical, but it does help you. There are many study guides out there for classes. A good one is ATI. They're on Amazon. I have a whole used set of them. They are really good study guides. If you need one, that's kind of probably where I would send you. But they're not required. We just try to give a little bit of extra information if you need it.
Okay, yeah, I had seen on the Evolve course itself where you're able to shop for the books. I found the study guide for the actual maternal child nursing. So I just didn't know if that was the one that you guys.
That's a good one because it goes right with your book. There's one for Iggy also, your Ignavicious book, your med-surg book that we start in 3 weeks. Okay. Well, 3 more classes. We have this class, the next class, and then the next one we kind of start talking about stuff that's in Ignavicious. But there is a study guide for both books. And the good thing about this book is you use it for our semester. You also use it for 3rd semester too, and you use your OB book also because it's pediatrics. So these books don't just go away after our semester. You keep using them. Does that help you?
Yes, ma'am. Thank you.
You're welcome. I think it's got a bunch of NCLEX style questions in it too that really helps. All right, I think we've let everyone in. There's now 56. I'll keep my eye on it. That should be just about everybody because we waited 6 minutes. So I'm going to X out of that. So today we're talking about normal labor. This is labor without complications. We have a class in a couple of weeks where we talk a lot about the things that can go, oh, Jada, here you come. Got you admitted. Good, it's telling me. So we talk more about abnormalities in the next couple of weeks. But today, with few exceptions, I did add 1 or 2. This is the stuff that you would see every single day in the labor unit without any emergencies. So this is more fun when we're in class right here because I like to know what is everybody scared of when they go to OB. Students fall into 2 categories. Yay, 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 this is what I came here for, or I am freaking out, scared to death, and I'm glad I only have to go 4 days, and this is not what I want to do. What is that? Ooh, some ice just fell off our roof. Does anybody want to join in and tell me what they're afraid of or have questions about or concerns them? Do you want me to tell you what some of mine are? If you don't want to join in. Pain is a very common topic that students have real issues with because we cannot get pregnant women that are laboring completely out of pain in most occasions. We can give them an epidural, we can give them some Stadol, but a large amount of women still have some pain no matter how hard we work at it. And it's very distressing to have a patient that you can't fix. Family dynamics is another one that always concerns me. It's a hot mess and you never know what you're going to get. You can get a nuclear family that has a mom, a dad, and 2 kids, to a hot mess, maybe going into DHS custody. It's Jerry Springer out in the hallway. Like, you never know what you're going to get when you get there. That is somewhat dependent on which hospital you go to, what kind of social situations you'll see. Especially for our men, it's a very intimate experience giving birth, and they're uncomfortable going in. For the most part, people don't care. A healthcare provider is a healthcare provider. I don't care if you're a man or a woman. You're a student that has earned, and that's what I believe, earned, because you've made it to 2nd semester, the right to be there and participate. We will ask your patient first if it's okay. I have rarely seen a patient refuse a man entrance into her delivery room because you're a professional and you're recognized as a professional, not anything to harm anyone. So most women, from my experience, have been quite welcoming. Culture is another hard one for me because different cultures have different expectations. Some cultures do not want a man of any nature in that room, including the doctor, the scrub tech. And it gets really hard when we have only one anesthesia provider for an epidural and it's a man. So it becomes a hot mess trying to find a woman if we can, or they don't get pain control. And it's really hard, but it's what they're asking for. So we're kind of stuck in the middle of how to manage this person's pain, but we can't get them an epidural. Does that make sense? So everybody has a different issue going in. That's the people who want to go in. There are people who want nothing to do with OB. You go for your 4 classes and you're done. All we ask of you is that you participate. I don't ask that you love it and want to work there and have dreams about it all night long. Okay, nightmares. All I want is you go in there, you spend your 4 days, you participate, you learn, because these questions are on NCLEX. The HESI that we give at the end of the semester, which some people need to pass, has 40% OB questions. So it's not something that you're never going to see again if you can just kind of avoid it. So make sure that you get the most out of your experience that you can. This one's much more fun in class. This is the normal reproductive tract of a woman. Hopefully you know this and you've done it in anatomy, probably even high school, but it's going to be important that you know the female anatomy as far as a uterus, a fallopian tube, and an ovary, because when we get to our class on the complications, which would be an ectopic pregnancy that can gestate in the fallopian tube and it's an emergency and the woman can die. Also, if she has pelvic inflammatory disease from an STI, it can cause scarring of the fallopian tube, which can make her either infertile or she can't ovulate at all because it never gets past that point. And it's just a big hot mess if we don't know that she has it ahead of time. So those are 2 of the diseases that we look at. So make sure you are completely aware with the female reproductive tract. We don't focus so much on cell division, cleavage, implantation, embryo and fetus as you probably would have in another class. We're more focused on childbirth. But what you do see is you see on this PowerPoint, do you see it where it says implantation on the left side of the uterus? That's where we want the cells to implant. It could be on either side or up at the top, which would be the fundus area. What we don't want is the cells implanting themselves towards the bottom of the uterus, close to the cervix. Because what will happen is as the baby grows and the placenta grows, it will actually cover up the exit for the baby right there on the cervix. So the woman will continue to bleed, and it's a really big deal. A lot of them can deliver term. They just need a C-section. But this is where we would like to see the fetus, embryo, I should call it, implant in the uterus. We do not want it there. If it's at the bottom, it's called a previa, a placenta previa. And literally there can be frank red blood coming from the placenta before the cervix has even started to dilate when she has an extremely premature infant. So that is a problem that happens, but this is our goal because this is normal class. Um, Here's some more cell stages. I don't know how critical it is to know all of them by the day, but in general, what happens is oh the egg releases from the ovary, travels through the fallopian tubes, becomes fertilized, begins to divide, come down the uterus, and implants. So when we talk about labor, what are we talking about? And I can make this super easy. Oh, let me let Susan Hinkle in. Admit. There you go, dearie. What distinguishes labor from false labor? False labor is also called Braxton Hicks contractions. So the differences between the two are: one, the uterus must be contracting, and the big goal here is that the dilation and thinning of the cervix. If there is no dilation and thinning of the cervix, there is no true labor. So what happens often is a woman will come in to urgent care, which is our version of the ER, and she'll be having contraction. They can be fairly regular contractions. They can be fairly painful. As long as she's not ruptured, we're going to put her on the monitor for 2 hours, and they're going to check her cervix. Her cervix is, say, a 3, because there's people that walk around with the 3 all the time. So we put her on the monitor, we watch her contractions, we watch the baby, we check her cervix, it's a 3. We check her again in, say, an hour, it's still a 3. We check her again at the end of the 2 hours, which is why we've had her on the monitor, and she's still a 3. She'll be going home as long as the baby is safe, because that's not labor. Labor only involves the dilation and thinning of the cervix. Other than that, not labor. So a series of continuous and progressive contractions that dilate the cervix. It occurs spontaneously in a lot of cases. Sometimes we do induce women for various reasons, but nobody stays pregnant forever. Eventually your body will go into labor and you will have a baby. It could be 42 weeks, which we do not like, and I can't think of very many women that are allowed to go to 42 weeks without being induced. 37 weeks, we did not that long ago, and I'll admit I did this. 38 weeks, I had a really rough pregnancy. I was done with it. My doctor said, yep, 37, 38 weeks, we're gonna induce you. I'm like, awesome. Well, we don't do that anymore, and let me tell you why, because you think, well, what's the big deal? It's term. What we were doing is we were inducing labor to women who weren't actually 38 weeks. You could easily be 36 weeks, and we thought you were 38 weeks. So you are induced, you have your baby, and lo and behold, it's a premature infant. And they would go to the NICU, they did fine, but they would spend a few days there as they were respiratorily not very mature. And they couldn't regulate their temperatures because they weren't 38 weeks, they were 36 weeks. Does that make sense? So very few women are induced early. It's an insurance thing now. You'll see like little name tags on your nurses that say, keep me cooking till 38 weeks, basically, that we do not induce you just because you're tired. I'm very appreciative that we did that, but anymore, I really do see why we don't do it, because you're going to get some late preterm babies that will have to go to the NICU for at least a few days to be stabilized. So 38 weeks is our golden number. 38 to 40 is what we're looking for. 37 weeks and above, preterm, 42, and after, postterm. The problem with postterm babies at 42 weeks is that the placenta is no longer doing its job. It is meant to last 40 weeks, and then it really does not oxygenate the baby very well. The baby will become stressed out. It'll pass meconium into the amniotic fluid, and then we have a very sick baby. Doesn't really hurt mom, but it can make for a really, really sick baby. So that's why we don't do that anymore. So in class, I say, who can tell me what starts labor? And I hear all these answers, and you know what the answer is? We don't know. Nobody knows. We can do all those things in life, but we don't know. It could be related to, ooh, you're tardy for the party, admitting people. It could be the stretching of the uterus as the baby grows inside of it. It's a good guess. Or the baby's head becomes engaged with the cervix and it makes oxytocin and pituitary hormones release to start labor. I don't know how I feel about that one, because women often have babies that aren't engaged in the cervix. They're still high. So I don't know about that one. Oxytocin stimulation, makes contractions, the woman's body starts making it on its own. You have more estrogen versus progesterone. This is actually probably what I think, because it's what my OB doctor told me what happens. Or placental age, it gets older and older and older, and the older it gets, it starts to trigger contractions at a set point. That doesn't explain preterm labor. Sometimes we know preterm labor is from an infection or something like that, but we don't always know either. So no big deal. These are in your book. These are set out. Maybe, maybe not. Who knows the answer? So premonitory means signs of labor, that labor is coming shortly, but it does not necessarily mean you are in labor. So Braxton Hicks contractions that we were talking about earlier, those are practice contractions. They can get really painful, but it does not mean that you are actually in labor unless your cervix is dilating. Lightning is an interesting one because you would think it means going up, but it actually means going down. It's when the fetus, the baby, starts to settle down into the pelvis instead of being up on top of the pelvis. So they call it dropping. If you, oh, the baby's dropped, it's coming soon. That's what it's talking about. The pregnant woman that has lightened doesn't look the same as someone who has not. Increased clear vaginal secretions. Yeah, it can be, but there are increased vaginal secretions from day one of pregnancy. It's the whole time. So that is a premonitory sign, but it is definitely no sign that you're in labor. A bloody show. This is also talking about your mucus plug. It's a wad of snot that goes up in your cervix. So bacteria cannot get up to the baby and get around the sac that it's in. It is a premonitory sign, and here's what I'm going to tell you. I've seen them brought into labor and delivery in jars. Yes, that we believe you. This is what came out. We totally get this is what happened, but it does not mean you're in labor unless your cervix is dilating. Energy spurt, it's called nesting. About 3 days usually-ish before someone has a baby, they get this burst of energy to clean the house, make a bunch of hot meals to stick in the refrigerator, make sure the nursery is perfect. It's a sign, yeah, you're probably getting pretty close, but it does not mean you're in labor. And a small weight loss, the woman will actually drop a tiny bit of weight. So these women will come into our urgent care on OB, and we'll hook on the monitor, we'll look at them for a couple of hours. Lo and behold, you're not in labor, those were just Braxton Hicks. What do we say to this woman when we discharge her? And this is really, really important. Do we tell her, yeah, don't come back here until your contractions are, super close and you're really in pain? No, we don't say that. We say, great job. You are so close. If anything like this happens, please come back in. We are happy to take care of you. We have plenty of staff and plenty of room. Because if we make people believe that, or make them feel at least like they are not being heard or validated or made fun of, especially when she urinates on herself and it's not amniotic fluid, she's not going to come back. We want this woman to come back, especially if she's that close to term. One, something bad could be happening that we can catch early. Two, she could end up giving birth at home because she's afraid to come back and talk to us. So welcome to OB. We're going to take great care of you. Anything else that concerns you, you come right back up here again. So these are the big ones that we're looking for between true labor and false labor. False labor, also Braxton Hicks. So true labor contractions they're at regular intervals, regular frequency, duration, and over time, they're getting more intense. False labor, they can come, they can go. Sometimes they're 3 minutes apart. Sometimes they're 5 minutes apart. They're not getting any worse. They can be uncomfortable, but they're really not getting any worse. And if you take a break, they should start to go away. If not, you probably want us to come check you out. Discomfort, true labor, it starts in the lower back and it wraps around to the abdomen because the uterus is contracting. False labor, lower abdomen and your groin. So there's a little bit of a difference where the pain is, but it's sometimes really hard for the woman to tell the difference. And that's okay. Come on in and let's check you out. Sitting in the labor and delivery unit, you're going to see it. Most of the hospitals do not have a nurse that just answers the phone. Some of the bigger doctor groups do, but by golly, they should, because it's not like the ER where you call up there and go, hey, I think I broke my arm. Should I come in? That you come in. In the OB unit, people are scared and they don't know if they should come in. So the labor nurses talk to women all day long, trying to decide what should be done. and they deserve a staff person dedicated just to doing that, but most of them do not. They do have a distinct urgent care area that is staffed usually between, I'd say, 9 and 5 during the day for non-stress tests and things like that. But when in doubt, tell them to come to the hospital. Comfort measures, we're going to have her walk, change positions, lay on her left side, drink something to see if the contractions will stop. If the contractions keep going, despite doing this, there's a good chance that she's actually in labor. If you take a break and they stop, that is not real labor. The one that I was always heard was, she's like, I haven't felt the baby move lately. So we're going to say, okay, so have a snack, have a drink, lay on your left side, and if the baby doesn't start moving after 15, 20 minutes, come right on up here so we can put you on the monitor and check your baby out. Sometimes just that snack will get it going. Cervical change, and this is the big one that we've been talking about. Increase in cervical dilation and effacement. We check you, your cervix is a 3. We check you again in an hour and it's a 4. We check you again and it's a 4.5 even. You're likely in labor because it's changed a lot in just 2 hours. Welcome to OB, you're gonna have your baby. Any questions? Nothing? It's hard to do this. Oh, I've never done this exact class by Zoom. So here's when you should go to the hospital. Contractions. Well, we just talked about that. It's really hard to tell when a contraction is a contraction or not a contraction. People come in all the time, women do, for contractions, and it's not a big deal. We put you on the labor, we put you on a bed, we trace your baby's heart rate, we look at your contractions, we check your cervix, bam, we're gonna hopefully figure out what's going on. So come on in and let's check you out. Like we just said, a pattern of increasing frequency, duration, and intensity of contractions. They are different. Has everybody done their ticket to clinical for tomorrow? 1, it's required. 2, it's your best friend because it has a lot of terms on there that we have never talked about in nursing school, and we do automatically start talking about them now. So you really need to know what they are, or tomorrow and Wednesday at clinical schools, you're going to be super lost, and you don't want to be super lost. You want to be completely engaged because you only get 4 days there in nursing school. Nullipara. Can anyone tell me what a nullipara is? A nullipara is your first baby. So if this is your first pregnancy that is coming to term, you are looking for regular contractions that are 5 minutes apart for 1 hour. That's a long time, but they need to be 5 minutes apart. Multipara, you have a little bit longer because this is your second or 15th baby. Regular contractions again, but they can be 10 minutes apart for 1 hour. You don't want to stay home and labor too long if you've had other children, because labors are shorter usually for people who have had more than 1 baby. So a multipara who stays home until they're 5 minutes apart has a really good risk of delivering the baby either in the car, in the house, or right outside the hospital. So come on in if you're having regular contractions. Another reason to come in is if you think your water's broken. That's ruptured membranes. This one happens all day long, every day. And I'm the NICU nurse or the baby advocate for labor. So I know about it, but it's not my forte. And it used to be there's a 24-weeker coming in and she's got leaking fluid. I'm like, oh my God, the baby's coming. What am I going to do with the 24-weeker? I'm the only one here. You know what really is 99.9% of the time they've urinated on themselves. And it is not their fault. It's the pressure of the baby's head against the bladder and the ureters. And everything just isn't quite as toned down there as it was. And you cannot tell the difference. I'm going to show you how we do. But she can't tell the difference. So have her in, check to see if it's urine or amniotic fluid. Nurture her. If it's urine, tell her, come back next time it happens and we're going to check you out again. Bleeding, a little bit of spotting is okay. But very much frank red bleeding is a good sign. Just come on in, let us check it out and see how much blood it actually is. She'll say, I'm bleeding a lot. They'll come in and it really isn't a lot. Or you'll have someone that come in that's hemorrhaging. They're like, I just started bleeding and literally there is blood running off the bed in the urgent care room. So if you're bleeding, come on in, let us see what's going on. Here we talked about a second ago is decreased fetal movement. Super common as the baby gets close to term and delivery, it's tight, so it can't move as much. So usually it's just fine. So what we tell you is eat a snack, have a drink, lay on your left side. If the baby doesn't start moving, come right on up here so we can put you on the monitor and make sure that the baby is okay. Other concerns, pregnant women have like this weird sense of what's going on with their body. I don't know how they do it, but they do. If she calls up there and says, hey, should I come in? Something's just not right. And we're like, so what are your symptoms? And she tells us, she's like, nothing really, but I think something's wrong. Come up to us, come as fast as you can safely, and let us put you and your baby on the monitor to make sure that your baby has a good heart rate, that something hasn't gone wonky with this cord or the placenta or anything like that. If that woman tells you there is something not right, she's probably right. There is something wrong, and she needs to come right on up so we can assess her. No big deal. We put you on the monitor. We reassure you everything is fine. You come back if there's anything else wrong. Period. Always, always, always never delay someone coming in. I'll tell you the truth, I missed this question when I put it in this lecture. So the nurse is working in the OB clinic. ACEs happens all the time. Which of the following statements is most concerning? A 27-weeker calls up there and says, my resting heart rate is usually 60. I can't believe it's 75 right now. Or a 25-weeker stating, and anything before 20 weeks goes to the emergency room. Any woman pregnant 20 weeks to 42 weeks comes to the OB unit. So you can pretty much, if the phone rings up there, it should be someone past 20 weeks. If not, they usually send them to the ER. A 25-weeker saying, I just get dizzy so easily. I have to sit on the side of my bed before I get up in the morning for quite a while. So what does that sound like that is? To me, that sounds like that's orthostatic hypotension. She needs to dangle her feet, sit at the side of the bed for, even if it takes 5 minutes for your body to adjust, having so much more body fluid until you get up so you don't fall. Let's see here, a 30-week client stating, since yesterday I've started to urinate without even knowing it. It's like a slow, constant trickle, and I cannot really control it. I've been saturating pads with urine since yesterday. Or a 19-week gestation client stating, I know I'm supposed to come to this appointment with a full bladder, but I just can't wait. Somebody want to chime in with the answer, because these aren't nearly as fun as not in class. Anyone? No?
How about a 30-week client?
Yes, good job, Taylor. What's going on with her?
She's lost all control of her bladder, which would be concerning considering where the baby could be sitting.
No.
Nope, it's amniotic
But thank you
fluid.
for chiming in. I appreciate it. Anyone else?
Her water broke.
Yes, exactly right. This woman is ruptured. The trickle of urine. Yeah, it can happen, but she's ruptured. I would guarantee you a 30-weeker, because it's pretty small baby still, she has prematurely ruptured her membranes, which is bad. Who can tell me why it's bad?
Baby hasn't fully developed their lungs.
Yes, a 30-weeker is very premature. What else can happen if she's been ruptured for a day or two? And
The
just
risk of infection for a baby and mom.
very good. Yes, that woman is at an incredibly high risk. If she has ruptured, her amniotic sac is ruptured, it's leaking onto the pad. It's been leaking onto the pad since yesterday. This is bad. OU and the bigger hospitals, 30-weeker, maybe, but they can sometimes try and stop labor, but we can definitely give her antibiotics so she doesn't get sick. And as we deliver the baby has a dose of antibiotics on board too. So yes, anybody calling up there saying, I'm leaking urine, come on up here and we're gonna look to see what it is. And this right now is how the hospitals check. There used to be something called like, I don't know, a Fern test or something where they would look at it under a microscope to see. But Amnisure is what I've seen used lately. No big deal. You stick a little cotton swab into the cervix area. You swab it around. You look at it, and it will tell you if what is inside of her vagina is urine or amniotic fluid. If it's urine, ACEs. Go home. Let us know if you have any more problem. If it's amniotic fluid, welcome to labor and delivery. You won't be leaving this unit without a baby. Does that make sense? So there are ways to check, but we would never say, oh gosh, you're just peeing yourself. Don't come up here. Very well could be. I've seen it go both ways. Okay, so we're moving on to another topic. These are Leopold's maneuvers. They're in your book. Have I ever seen an OB nurse do this? Christina's gonna say I'm lying, but I've never seen anyone do it. But they're in your book, and I learned them in nursing school, so you get to too. I have seen a few doctors do it. Mostly, my experience has been this has been replaced by the ultrasound that we have now. Every OB unit has a portable ultrasound that they can look very quickly to see what position the baby's in. But what the practitioner can do is put their hands over the uterus, palpate the baby to figure out where the bony parts are to see what position it's in. And mostly what we're looking for is to see if it's breech. And I'm sure back in my day, this was really, really important, but ultrasounds are so common now that you don't really see this done. They'll just grab the ultrasound machine. There's one sitting in the urgent care area, see what's going on with the baby. But it's right here. If you needed to find fetal sounds before you're putting the monitor, the straps on the baby and mom, sometimes you might see them kind of try to figure out where the baby is located so they can get them over the right part. But we really haven't used them a lot to find out what is breech or not in quite a while. So everybody is caught up. Everybody's in. Okay, so labor is broken down into 4 stages. Someone's here, somebody new. Okay, so 4 stages. The first stage is broken into 3 more stages, but it's the only one that's broken down into extra stages, okay? First stage of labor is from a cervical dilation of 0 to 10. Easy peasy. 0 to 10. And we're going to come back and look at the first stage in just a minute. Second stage is 10 centimeters until the baby is delivered. Third stage is from when the baby is delivered until the placenta is delivered. So as long as the placenta, baby holding skin to skin with mom, everything's wonderful. They're working on getting the placenta out. She's still in the 3rd stage of labor. 4th stage of labor begins after delivery of the placenta and continues for 1 to 4 hours after delivery. In general, the Oklahoma City hospitals that I've seen, it's 2 to 4. I don't think there is like a set number. It's a bare minimum of 2. I know that. So you're in the 4th stage of labor as long as we are having a fair amount of blood. If mom has had just a scant amount of vaginal bleeding from where the placenta detached, it's less than a pad an hour. We massage her fundus, it's nice and firm. She looks great, her blood pressure is stable, low bleeding. This woman is doing great. Then she can be transferred out to the postpartum unit. We used to have LDRPs all in one room now, or we did, but we separate them out now. You have your baby in one room, and then we pack you up, you and your family, and we move you to a postpartum room now. A little bit different, but nobody, I'm sure, leaves the OB unit, even if you've been there 6 hours. If you're still bleeding more than we would like for you to, you're staying in labor and delivery. You are still in the 4th stage of labor. 4th stage does not stop until the bleeding has slowed down, okay? Because dangerous things, the reason is on the OB floor, ideally, anyone in labor, even post-labor, 4th stage, has their own nurse. It's one-on-one nursing. That's the goal. Once you move out to the floor, your nurse can have up to 3 couplets, or it depends if they have a tech or not. But you are no longer a one-on-one patient that the nurse can constantly stand at your bedside, massaging your fundus, making sure you're not bleeding. So that's how we decide. So if we look at the first stage, it's divided into more stages, 3 stages. Hang on, let me scroll it. Oops. They look like breasts, don't they? So the latent phase, let me see if I can get this to scroll down, is 1 to 3, I do believe. There we go. It does not want to say the answer. Okay, we're just gonna leave it right here. So latent phase is 0 to 3 centimeters. Same if you've had 5 babies or 1. Most people, you can be walking around doing your grocery shopping. I was, and it was still my first baby, in the latent phase for days and days and days. 0 to 3. As long as you're not ruptured, we leave you there. You don't want to be in the hospital for 0 to 3 because unless you're doing a lot of contracting, that's not labor. 3 to 7 centimeters is the active phase. People are usually in a lot of discomfort at this phase. They're beginning to hurt. They want an epidural, but it stops at 7. And which transition is the rough stage. Women vomit. They don't feel good. They're saying things that they would normally not say, that wild animal look type thing. That is 7 to 10 centimeters, period. So the first stage is 0 to 3, 3 to 7, 7 to 10. And then the second stage, remember, she's at 10 centimeters, so we're going to move into the second stage. The second stage is when you start pushing, which would be 10 centimeters until birth. And then you're going to move into the third stage. That is the slide right above this. So behaviors of mom is extremely different between the latent phase to the transition phase, a totally different person. Hopefully, if she wanted at least an epidural, she can get one somewhere in that 3 to 7 centimeter phase, and transition won't be quite so rough. But I'm going to tell you, I, for one, had a great epidural, and I was still puking during transition. It's just what your body does. So that's the stages of labor. The next slide, you do not need to memorize. It is in your book, but it's not something that you actually need to memorize. But what you do need to understand is we can't leave you in labor forever and ever and ever. If you come in, we put you on the monitor, you're ruptured, you start out, say like on the left here, a 3, and then you're a 4. But if you're not dilating progressively and fast enough, you'll get a C-section. And you think, well, baby's doing fine. She's just not transitioning very well. She's stuck at 7 centimeters and she's been there for 4 hours. It's called a labor curve. And once you start to fall off the labor curve, and you understand why it's called a labor curve, because it's kind of like flowing. If you look at it, fish, Moody, you're tardy. Fish, you're tardy. You missed 30 whole minutes. This is the labor curve. And you can look at it, the time across the top and the centimeters. A little bit of falling off the labor curve is okay. But if you fall way off the labor curve and you are, say, stuck at this was me, 6 or 7 centimeters for, 7 hours, they're going to eventually come to talk to you about having a C-section, because it's really hard on the baby, and it's not associated with good outcomes. You do not need to know hour by hour what we expect you to be doing, but you do need to know if you go to OB tomorrow and they're talking about the woman in 4 has been in labor dilated to a 6 since midnight and starting to fall off the labor curve, this is what they're talking about. It's kind of confusing because the baby can still be doing okay. It's just not its time. And all we want when we get out of OB is a healthy mama and a healthy baby. I don't care if you have an epidural. I don't care if you have a C-section. I do not care who you have with you. I don't care what you do. All I care about is you coming out if you're healthy and you coming out with a very healthy baby. So these are the steps that the baby, they're called cardinal movements, to be born from inside the uterus to outside the mom's body. I'm going to tell you, this is not how I learned it, but this is how your book states. I'm going to show you why I don't like it. So what we're looking for first is the baby comes in. Here, let me show you. So this is the order that your book has it in. That is not how I've always learned it. This is how I've learned it. So I have an acronym for this, and do you want me to tell you a secret? I've known it for 32 years. Since 1991, I have had this stuck in my head, and I will never, ever, ever forget it. So do you want me to tell the acronym first, or do you want me to explain it as I go and you can try to figure it out on your own? Anyone?
Well, it says first, if you would.
Yes, I will. Okay, you ready? Every darn fool in Enid eats eggs. I know it sounds bizarre, but I had the OB teacher that was there for years and years. She recently died, but she had like 40 years of experience being at OU, and that is how I learned it. So your book is very similar, but it has the first 2 flipped. So I don't like it. But don't go, but Wendy, that's not what the book says. Yes, I'm completely aware. Will you be tested on exactly something that you could flip into and argue between a book and a PowerPoint? No, because that's not fair. All right, so engagement. That's when the baby's head drops down and becomes firm with the cervix. It's not floating up it's not floating in the uterus high. It has actually, what is the word for that when it drops? Who can tell me?
Lightning.
Yes, it is firmly had lightning and engaged with the cervix, okay? Descent is it's starting to come down through the cervix. Flexion, it starts to tuck itself into a little ball. Internal rotation, do you remember when we had the mannequin fired up with Christina last week and we said it was making a turn and you could see the head coming down and then it went from being turned like facing the left to turn to facing down? That's the internal rotation. It makes it easier for the baby to come out. Extension is when the head is getting really close to coming out and it kind of turtles. External rotation is whenever it's coming out and it turns that one last time as it's coming out of the vagina, which you saw it do that too. And then expulsion is, pooh, the baby has been delivered. So they're called cardinal movements and every baby should do this. If they're not doing this, mom's gonna have to work really hard to push the baby out. So, but this, if you want to have a normal delivery, this is what it looks like from the baby engaged at the cervix, through the vagina, and into the doctor's waiting arms outside of the delivery sitting there. Okay, you saw all of these, you just didn't realize that we actually do limit it to stages. I challenge you to, when you go to OB this week and you see a baby being born, not C-section vaginally, to see if you see these movements. Now, some of them are hard to see. The internal rotation is a little hard, but you can see the head usually. Extension, you'll see. External rotation, you'll definitely, because it makes a little twist right as it comes out after the shoulders. And then expulsion, which is into the doctor's arms. Here's another picture of it from your book also. It's kind of confusing to me, and this is what it gives. It has the same thing of what the baby, the movements that it makes coming down. If it helps you to actually see it in a uterus, this is here. There's also videos online, like animations. If you need to look at that too, that will also show you what we expect to see from the baby. Any questions so far? We're kind of going to move to a different area. It's a good time to answer them. Nothing? Good deal. We've been on the computer. Okay, so there are actually 5, which we'll touch on the 5th, but there really are 4, but there are 5 factors that interact with each other during childbirth. 4 things. We're going to break this down, okay? So we're going to start with the power, which is mom's pushing and the uterine contractions. The passage is mom's body. The passenger is the fetus or baby. And the last one, we're going to look at position too, but it's not technically one of these, but I like position. I think it's important because I want you to know what to expect. Psyche is mom's condition. How ready is she to have this baby? How supported does she feel? So the first one is, of course, power. Power refers to contractions of the uterus, which are not voluntary. She has no control over them. And the other is maternal pushing. This is exactly how we're going to get the baby out of the uterus and into the welcoming arms of its mama. These are the only 2 forces that get the baby out. The pushing cannot, remember, start until she's 10 centimeters. So those are the 2 ways the baby comes out. So power, it's referring to the force generated by the contraction of the uterine myometrum, which is muscle. So if you see the arrows there, it's the contraction that helps push the baby down against the cervix and out of the vagina. It can be accessed by a couple of different ways. Christina went over it last week for you. You can palpate the uterus, the fundus, and feel how firm it is. It can go anywhere from the way you feel up against if you touch your chin, see how it's kind of squishy, and then touch your nose, it's a little firmer, and then touch your forehead, very firm. That's kind of the progression that the baby makes with the uterus getting firmer and not firmer. So that's a sign of how well your uterus is contracting. You can also use toco memo, oh my gosh, we call it the toco, on the outside of the uterus, which were those 2 little straps you saw on the mannequin. And contraction force can also be measured by direct measurement of the uterine pressure using internal manometry or pressure transducers. We passed one of those around in sim last week, so we can either feel it with our hands on the outside of the uterus on the skin. We can put a monitor on it that will give us a good guesstimate of how hard the uterus is contracting. It is not precise and it does not equal this is all going well. Or we can put the monitor that we showed you inside the uterus. It kind of runs. I think I've got a picture up beside the baby. I've got a picture in here somewhere, don't I? I do. So hang on just a second. I'll show you. So this is my favorite picture. What do you people see here? This is a real labor. This is someone on the internet. This is them. She came on into labor. She waited a little too long and she's birthing in the hallway. What do you see? Someone's going to answer. I'm sitting here because I like it. Come on.
The baby's head?
Dad's catching.
Yes, dad's catching it. Who's delivering the baby? It's the dad. What is the woman, L&D staff, and the one on the right too, with her gloves on the left? Where's she going? Dad is catching the baby, and the labor nurse on the with no gloves on is just supporting her up against her legs. But yeah, the baby's coming out. If you can see down there by her knees where she's got her pants pulled down, that's the baby coming right on out. I've never seen one deliver in the hall, but I've seen several in a car, and urgent care. Occasionally someone will show up at 10 centimeters and birth in there. But yeah, the dad, the man, is catching the baby. So it's fun in class to laugh at, because that girl on the left, I have no idea where she's going. I don't know what she's going to get, but somebody should be down there helping dad. Contractions, if you can remember the diff, if that helps you at all. Duration, how long are they lasting? Intensity, how strong are they? And frequency, how far apart are they? That's what we look for in a contraction to see if they're forceful or not. Here's what we looked at. On the left, you see an external monitor, no big deal, stretchy, doesn't hurt at all. Put some ultrasound gel underneath it, fairly accurate, but there are larger women and then some babies that you just cannot track. So they can put it in internal. You'll see it on the right. Most facilities require that they're put in by a physician, but I have seen nurses put them in, usually in a semi-urgent condition, because we can't really tell what's going on. If you can't tell what's going on, or baby not doing well, call doc, turn off the Pitocin until we get an answer. Don't keep giving the Pitocin. I've seen it happen once. Permission, we do try to get permission from mom to do it. She has the right to refuse. We have the right to no longer give her Pitocin until a physician can come up there to assess the situation and see what's going on. If you cannot figure out the condition of the baby, we aren't going to augment your labor. All right, so that's just pushing and uterine contractions. Any questions? That's power. Questions? All right, so the passage is the next thing we look at. The passage is the cervix. When you are not pregnant or you are very early pregnant, cervix is not dilated, it's not effaced, it's thick and it's closed, and you can see it right there on the left. And if you practice with our, they're not mannequins, but our fake vaginas, if you stuck your fingers in them to feel it, you felt the one that was, I think she's probably like maybe 1 centimeter. 1 centimeter is also called a fingertip. So if you say that if you have a nurse go, oh my gosh, she's just a fingertip dilated, so it's going to be a long day. That's what that's talking about. It's closed. The other thing that if someone is not in labor early on, you're going to have them say she's going to come in, maybe say she thought her water ruptured. We're going to check her. I don't know that we would check her. Someone, for some reason, comes in and we need to check their cervix and say they're 26 weeks. What we're looking to see is the cervix closed, which this one is on the left. It's closed. It has no opening. Thick, See how nice and thick it is? It's still got the barrier between the baby and the vagina. And what is the position of the baby? It would be closed, thick, and high. The baby, often, whenever it's still this thick, is not engaged with the cervix yet. So if you see that on the board tomorrow, if it says CLTH with an arrow pointing up, I usually do this on our whiteboard at home. Closed, thick, and high is what it says that baby is. It's not likely that just giving her some Pitocin could start her labor very easily. She would probably need some Cervidil or another medication to make the cervix ripen. It, I know, isn't that funny, cervical ripening. It will actually start to thin it out, which will be greatly beneficial. So she'll come in the night before, she'll be given the medication as close as they can get it into the cervix. They'll check her then, but they'll hopefully, when they check her again, and it's time to start the Pitocin 6-8 hours later, her cervix will have already started to ripen or dilate some and get thinner. Next picture on the right, your cervix is 50% effaced and not dilated. So what we're looking at is that if you see how thick it is, it's half as thick as the one right before it on the left. So dilation on this, it's not dilated. That one's about the same. It would be a fingertip or one or less. So not really dilated. But as you can see, the cervix is starting to thin. So we are making progress. On the next one on the right, 100% effaced, because see how thin it is, and dilated to a 3. So there's no cervix left to palpate. All you can do is tell it's 3 centimeters open. And the one on the right, no more cervix left, not effaced. You can't see it at all. It's just disappeared. And you check her to see how dilated it is with your fingers, and she would be at 10 centimeters. And so she can start to push now. Why do we wait until centimeters 10 to push? You think, well, the baby's only like 26 weeks. Why do we have to wait to 10 centimeters?
So they don't
And she can cause tearing.
Yeah, you can tear your cervix, which is very, very, very vascular, and repairing them is very, very, very hard. So that's why we don't ever let a woman push until she is 10 centimeters. Even if the baby is small, we still wait to 10 centimeters, because yes, a cervical laceration, a cervical lac is not pleasant, and they are hard to repair and very vascular. So 10 centimeters is, and it's fairly frequent. You're going to have a woman that's an 8. She's like, I need to push. We're like, do not push. I need to push. Do not breathe with me. So we're going to breathe, calm, and tell her why we can't let you push right now. We've got to get you to 2 more centimeters to make everything safe. But it's that they want to push, but you cannot start pushing until 10 centimeters. Okay, so more about our passage. This is the same thing you just saw, but it's another picture. I try to put a few pictures in these. I know it makes it long, but people learn in different ways. So sometimes one picture will help one person and another will help another. If you don't like it, you're welcome to just scroll right on past it to another picture that makes sense for you, okay? So the one on the left is just like before, thick cervix, thick, not effaced at all, and it would be closed as well. In the middle one, you can see it. Can you see it? Let me see if I can scroll it down just a little. It won't scroll. I don't know what part you can see or not. It's starting to efface. It's pretty much all effaced. I can't scroll down, I'm sorry. And then the one on the right is completely effaced and dilated. Then you can't see it, 10 centimeters, time to push. Here's another one. To me, they look like balloons, but it's how different they are between people who have had a baby they're on the right, and not had a baby on the left. After you've had a child vaginally, your cervix is never exactly the same as is most of your body ever, ever, ever again. So how thin the cervix becomes is different between someone who's had a baby before. What's it called if you've had a baby before?
Multipara?
Very good. And who's the first baby?
Nulliparous.
Yes, very good. And I'll tell you, if you're looking on the board up at the labor unit and you're trying to figure out what the board says, you're like, there's all these weird symbols and I don't know what these letters, it's like hieroglyphs, I don't know what this means. If you see a circle, completely circle, and in the inside of it, you see a dot. So it's a circle with a dot in the middle. That is lingo for first baby up in the OB unit. So you can instantly tell, okay, so this is her first baby. She is 2 centimeters dilated, 50% of face in lingo on the board. This woman is not going to deliver during our shift. It's going to be midnight. Or if we get it there and there's no first baby and we look at all the hieroglyphs, that, yep, this is her third baby. She's 80% of face and dilated to a 6. Awesome. She's going to deliver for us today. We want her. Does that make sense? So
Are there other symbols for multipara?
no, just first baby. Isn't that crazy? First baby. I'm just gonna give you a drink. But you will see a circle and a dot. If we give you a circle and a dot, you're gonna be prepared for a very, 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 very long labor day. You're gonna go through lots of checks, probably get her epidural put in if she wants one, but it's gonna most likely be a day of labor and not a delivery. So when I look at the board, trying to get them to help me make assignments, that is one of the things I look at. So if you're like, well, Wendy, why didn't you give me Miss Mary here, but you gave me Miss Jane? Well, I gave you Miss Jane because the chances of Miss Jane delivering a baby today are about 95%. Does that make sense? And I'll show you the board if you're with me at Southwest. I know right where it is. Baptist has Integris has one too, but it's a huge board and you can see it. It's like a giant TV screen and it tracks every patient on it, even the postpartums, but it tracks where every single patient that's back in labor, how they're progressing. So we can kind of tell, hey, this woman's been pushing in that room for 6 hours. There is something not right. My guess is she'll get a C-section. Does this kind of make sense? So the codes aren't made to confuse you. They're made there to help us kind of keep a plan. So this is just another picture. If you've had more babies than one, on the left, you see it's the brown part, the big thick part, that's your cervix, early, and then at the bottom of the left, it's completely effaced, and on the right, it's completely dilated. Same thing on the right, it just never looks the same ever again. You can just kind of tell from complete dilation on the left to complete dilation, the one on the right. It's a much bigger opening as well, which is one reason they don't labor as long, because your body does not go back to being exactly what it was before you labored for this child. All right, we looked at this last week. 1 centimeter, 2 centimeters, 3 centimeters, those are all still part of the first stage of labor, the latent phase. This woman is probably still walking around taking care of her 5 kids for a week like that. I was a 3 for weeks and weeks and weeks, not ruptured. It does not mean you have to come to the labor unit just because they say you're dilated. Of course, the further along you get, the more chance that you need to come in. All the way up to, if you want to picture how big the shoulders of a baby is, it's 10 centimeters and it's the size of a cantaloupe. Isn't that huge? You don't really think about it, that it really is a feat of nature that a baby is born and you go from being closed, which is smaller than a blueberry, to the size of a melon. Okay, so let's talk about rupturing of membranes. If a woman, and I had to learn this even fairly recently because I'm the NICU nurse, man, I don't know. Okay, so if after 37 weeks, your water breaks, you come into urgent care, we swab you, and yes, you are ruptured. That is called premature rupture of membranes, and it has nothing to do with a premature baby. Isn't that weird? I always thought it was, but that is not the answer. Nothing to do with a preemie. All it means is that your membranes ruptured, your water broke before labor started. So you come in, we assess you, you're barely dilating, but you're not in labor. You just ruptured your membranes. You're not leaving the hospital until you have a baby, unless it's super early and they try to keep the baby in longer, but we're not worried about that today. We're worried about the normal delivery of a healthy baby. She's going to start labor and she's going to start contracting really, really soon after she ruptures. But even if she's not dilating, she stays there with us. We can't let her leave. There's 2 reasons, and I'm going to show you the next one. But one of the biggest is related to infection. Now, if it ruptures before 37 weeks before labor starts, but gestation-wise, you're still before 37 weeks, that is a P-PROM, which is premature rupture of membranes. And you'll see this on that board that I just talked about, trying to keep up with who's doing what and what their body's doing. You'll see this written on the board, P-prom or prom, if she's ruptured. If we rupture them for her, I'll show you a picture. It's called AROM, which would be artificial rupture of membranes. So there's 3 things you can see up on that board if she's ruptured or not, or did we rupture for her? The only reason I could think that we do it still is rupture someone's membranes, and we do it with like a crochet hook. We talked about it in Zen the other day. We're trying to get her labor started. She's come in for some sort of an induction. She's 3 centimeters dilated. We're going to rupture her and hopefully use it to augment her labor. And we talked about 18 to 24 hours is the max that someone can stay ruptured before they get a C-section. And the reason is infection. The chances of an infection infecting the baby and the mom is a lot higher. Women before, 100 years ago, I know it sounds bad, but it wasn't that long ago, women died in childbirth all the time. I think I think it's like a 20% chance with each pregnancy of dying sometime between the time when you were impregnated and the time you delivered your baby. I like history. There's a woman who had been the Queen of England, but she died in childbirth, as did her baby. So if you ever want to talk about British history, I'm your woman. But bad things happen when we leave women ruptured, walking around doing their own thing and not being in the hospital. So we have PROM, she ruptured before she got here. PROM, she ruptured before she got here and the baby is not term yet. And then there's AROM, which we ruptured for her. And you'll see all of those. Let's see here. Oh, I like this picture. So on the left, you can see there's the doctor. We don't do that. The doctor rupturing the membranes, so the water will all come out, fluid right out. So the problem with rupturing people before they're actually in labor, or if we go back to the picture of every darn fool in Enid eats eggs, if that baby's head is not firmly placed into the cervix, as this one you can see it looks nice and firm on the left, what can happen is, if you look at the right, I've got another picture too. You see the baby's head down. You see where the cord is right up there, where it's normally in position? On the right, when the water ruptures and the baby's head is not engaged very well, it can slip past the baby's head and come out the vagina. And literally, you will go to do a cervical check and you will feel a cord there. I've seen several of these. It's no one's fault. It's just one of those things that happens, but it can easily lead to the fatality of the baby. So it's really bad. Literally, someone will jump up on the gurney that mom is placed on, stick their hand into her vagina and try to lift the baby's head up off the cord right there that you see. Because what happens if that cord is squished by a heavy baby head?
Loss of oxygen.
You're not getting oxygen.
Very good. Yes. There is no more circulatory oxygen or blood getting to that baby anymore. So they're going to get more and more hypoxic until we can do a C-section of that baby and pull them out with a C-section. I've seen really, really good outcomes. It was a small hospital. We had it happen twice. Great outcome. Baby did great. I saw it happen in one of the Oklahoma City hospitals, big hospital, full team of staff there. We were all there waiting, and the baby did not do well. It lived, but it did not do well. It was not well. So it's no one's fault. It doesn't matter where you are. It's just when did it happen? So right after, if they're AROM, right after they rupture, the doctor hangs around hopefully for a few seconds to make sure. But it's just one of those things that it just comes out, because when you see a cord next week, they're slippery. So it does happen, and it's called a prolapse cord. We're going to cover it again too later on in the class, but here's a picture of exactly what happens. It makes it a little bit easier. You see the little space where the baby's head, the cervix isn't completely dilated, or it's kind of mostly dilated and mostly effaced, but you can see a little bit there on the left, and you can see that little area right there on the right. And you see the baby's head where it's smashing up against the uterus. That baby's head is squishing it. So the nutrients and oxygen delivery and removal will no longer work for that baby. So this can happen. We ruptured mom an hour ago. We come in to check to see what she's dilated to, stick your hand in there to see, try to feel her cervix. And what you feel is a cord sitting there between the two. So the nurse is going to stick her hand up in it, up into her vagina, into her uterus, lift the baby's head up off the part we hope at least that we think is getting squished so the blood can flow. The nurse jumps on the gurney, rides with her hand in the vagina. We take her straight to the OR. Someone has a very crampy hand. The NICU team hopefully gets there and they'll do a C-section and pull that baby out extremely emergently because she can't deliver with the baby. She could, but she can't deliver a healthy baby with a squish cord. Does that make sense?
I have a question.
Yes. I love questions.
So in the event that a nurse is in there alone and this is to happen,
Yes.
are they expected to yell out?
Push the call light on the bed. And if you can't reach the call light on the bed, tell mom to push the call light on the bed. She has no idea this is happening. Mom does not know that her cord is prolapsed. Cords have no nerves in them. So she has no idea this has happened. So if you can't get to the call light, you have a family member, go out to the hallway and tell them what's happened. And somebody will come flying in there at the speed of, with flames behind them. And there'll be one person with their hand lifting the baby up. There's going to be another person disconnecting mom's bed from the wall. You know what I mean? The electricity and the call light and all of that. And then 3 more people will appear to start running with her back to the OR. Anesthesia will be notified of what's happened. They will be ready to put mom to sleep. So we don't have to wait. So they're going to, like regular surgery where she's intubated and not just an epidural. Most likely she'll be put to sleep emergently and we'll have the baby out. Probably in the operating room, if we're all ready to go, I'd give it, Christina, I wish I could ask you, I'd say 5 minutes at the most from finding this to getting the baby out. It's quick. Does that make sense?
Yes.
But that nurse cannot take her hand. It cramps. Your hand is going to cramp badly because I've been asked to help with that. I'm like, I am the baby nurse. I'm over here getting your baby area ready and I don't do that. But it's fast. Sister, it is so fast. From the time that nurse reaches in there and she's like, oh my God, there's a prolapse cord. She'll stick her hand up. She'll try to get the baby's head off of it. At that time, someone is screaming or not screaming. Oh my God, there's a fire. Not like that, but she's pushed the call light. A family member has gone to get another nurse. They come in, they say, what's going on? The other way that this can be found is, you know how they monitor the baby's heart rate at the desk with some of those strips or monitors on the abdomen? If a baby's doing extremely poorly and it's really compressed, you'll be able to tell on the monitor because the baby's heart rate will start to go down, is another reason. So the baby's heart rate's going down. We look at it at the desk. We go in there to check to see what's going on. And that's also when you can find the prolapse cord. Because if the baby's heart rate is going down steadily, you're going to get lots and lots of people in there automatically to come see what's happening. Do we need to turn her, if we assess her and there's no prolapse cord, do we need to turn her on her side? Does that make sense?
Yes, because I was actually going to ask about flipping the mom to another side as well.
With this,
I'm here, Wendy.
thank God.
Question. Yes, we flip her on all fours if she hasn't had an epidural to help reverse gravity. We put the mother on her hands, like
Right.
she's on her hands with her
Like a
head.
dog. Hands and knees.
Yeah, if she has had an epidural, we do Trendelenburg
Head down.
with our hand up there. But the soonest, the quickest C-section I've ever been in was 7 minutes.
Hot dang, that's pretty quick.
From the room to the OR, and it was probably 100 feet. We were going 100 feet to get to the OR because our ORs were on the floor.
Right. Were too. It's quick. As quick as feasibly possible. Does that make sense? Did that answer all your questions?
Yes. So is it standard for there to be an OR on the labor and delivery floor?
Every hospital I've ever worked at did. Yes. Some multiple, even Southwest. They usually mostly just use one OR, but there is a backup right next to it in case something happens.
In Seattle, ironically, our OR was not on.
Oh, are you kidding me?
No.
Oh.
And sometimes those ORs are all full. Like even if they are on a unit, they could both be full. Like,
Yes.
and we'd have an laboring mom with the emergent situation, and we have to run down to wherever the main OR is. So,
I worked at Moore before the tornado took it out, and we only had one OR. It was beautiful, but we only had one OB-OR, and we had someone, they just moved her to the table to do like a routine C-section, and this happened actually. And literally, they got the mom off the table, back into her bed, swabbed it down to the best of our ability, and put her on it so she could get a C-section. After that, we started scheduling, scheduled C-sections were down in the main OR after that because it was a systematic problem that we really hadn't thought about. So
yeah, you need more than one
you
on
do.
no matter the size of the unit.
Yep.
You need at least 2 on a small unit. And then I've seen 3 at Mercy. When I worked in Atlanta at Northside Main campus, they had 8 floors of labor beds. We delivered 100 babies a day, and our OR was on the main level,
Oh
so we
my
knew we had to go
goodness.
down.
Did you have a dedicated elevator that was just for you guys?
Yes.
Thank goodness.
And it was a brand new building when I was there.
Thank goodness. So you had your own elevator.
Yeah, most places, there's a hospital in Tulsa, their OR is on a different floor. They have their own designated elevators.
Thank goodness.
Seattle had our own elevators. Yeah.
So this is the last, I don't think there's anything. This is one of the few abnormal things I wanted to show you. I think we do go through prolapse court again because it is such a big deal. And we wanted to make sure, I would not call it common. I would not call it rare either. If I've seen it several times, I would not call it rare. So I wanted you to know just in case something happens like that. But we're gonna cover it again. Let's do this part of the baby and then we'll take a little break. The other thing we're gonna look at, remember how Christina was talking about fetal stations, and that 0 is when the head's at the bottom of the pelvis, also being fully engaged. Do you remember her talking about the spines? Okay, so 5 minus 5, let's be specific, is a baby that is still up, not engaged at all into the pelvis. A 3 minus 3 is when the head is above the pelvis. A 0 is the head's fully engaged. A +3 station is you're completely dilated and the head is in the birth canal or vagina. And 5 is when the baby is crowning. Okay. And here's a picture. If this helps you, I like pictures. If this makes sense. So what we're looking for is called the ischial spine. But if you see the baby's head right over where the dashes are, that is fully engaged and at a 0 station. You're going to see this on the board in labor as well, and it's going to say something to the effect of -3, -1, 1, or -1, yes, +1, +2, and you won't really see a +3 because she's really close to having a baby. But if it says -3, she's going to be in labor for quite a while. So I'll show you when you get there, but that is something that we keep up with very closely because it tells us how soon the baby's going to be able to be delivered. And if it helps you at all, and yes, this totally happens, these pictures are wonderful. I think +4 is on the floor, if that helps you. +4, way, still up in mom's pelvis. +4, it's crowning and about to come out. Does that make sense? If it's easier to remember that way. But you will see what station the baby is at on the board. I call it work, but it's in the hospital. It'll be written there. All right, so we've been at it an hour and 15 minutes. Look at us. Is everybody, somebody else is tired. Anybody have any questions? Do you want to take a tiny break?
Can you go over the -5 station again?
Yep. Let's move back. This one doesn't, is 5 a number? Like, I don't know that I've seen a -5 very often. I know why I haven't. A -5 station is nowhere near having a baby. Do you remember when we talked about lightning and the baby dropping?
Yes.
It's moving from a -5, which is still free floating, down into the pelvis as a -3. A -5 baby is nowhere near being delivered. So that's why you probably would never see that one in the hospital. We're not worried that the baby is going to be born anytime soon. So it's still,
Okay.
it's just floating, free floating. It's just stuck in the amniotic sac. Its head's not locked in to the pelvis.
Thank you.
Does that make sense?
Yes, thank you.
It hasn't lightened yet. Anybody else? Do you want to take a break? Do you want me to keep going?
I say we keep going.
Well, keep going. If nobody else votes, you win. That's what happens when you don't vote.
Let's keep going.
Keep
All
going.
right. So +5 is crowning and the baby is about to be born. Okay, so I'm going to be completely honest here. This is where it gets hard for me. It's hard. It's hard to understand. So this is the part of the baby, the passenger, that we're going to look at. So the effects of labor on the passenger, that the passenger has an effect on, are the baby's head size, which is molding. We're going to look at that. Presentation. When you stick your fingers into her cervix, what do you feel? What position is the baby in? And it makes a huge difference as far as how she can have the baby. Lie is which direction the baby's going in relation to mom's spine. Attitude sounds just like you would think about it. It's how much of a fetal position is the baby in, or is it all stretched out? And then what position the baby's in. So let's do, let's see here. Let's do head first. So everybody knows that a baby has a soft spot at the front of its head. That, oh, be careful with his soft spot. That's called the anterior fontanelle, and it has a purpose. The one behind it is called the posterior fontanelle, and it has a purpose too. It's just a little bit harder to feel. The one that everybody's used to hearing about is the anterior fontanelle. The magic about the fontanelles, and these are called sutures. Do you see, like on the one on the left, the little long line running right through the middle of it, what would be towards the front suture and the occipital bone? They are actually not attached. This is why babies have soft spots. One, so their head can grow as they get bigger. Two, so the head can form to the size of the vagina so the baby can come out easily. I was stuck at, I think it was a 6 or a 7 centimeters for hours and hours and hours. And lo and behold, my baby came out with the worst cone head you could have ever imagined. To the point my husband got mad. They were laughing at him in the nursery window because then anyone can still come to the nursery and they were pointing. But the magic thing about a molding head, it goes away really, really fast. Like I would give it just a couple of hours. So these suture lines and the opening are where the bones can actually slip underneath each other to make it so the baby can come through the cervix. When a baby comes out, it could either be molded, which is like kind of pointed in the back, or it can have bones, all the bones you see can be slipping underneath each other. Just so it could come through. It's an amazing, amazing thing that every baby has. You'll see the baby being born. One of my favorite OBs, she's now the internist at Baptist, so that's all she does is stay there all the time in case something happens. She'd be like, and this baby needs a hat. So urgently. So she's like, go get it a hat. So we'd get very quickly, we would put a hat on it because it was so pointed. And then mom would be like, what's wrong? Nothing's wrong. Your baby just has a pointed head. And lo and behold, 6 hours away, it doesn't look like that anymore. So when we're talking about head molding and what babies, the forces of labor that the baby creates, we're talking about its head molding. And I promise you'll see it all the time. This is presentation. Presentation, we're looking at what part of the baby is close to the cervix. Cephalic is what we want. The baby is basically upside down and head can engage. Okay, so remember we're talking about a free floating baby, like a +5. Do you see the one on here on the left? How it's not engaged with the cervix at all? That baby would be a +5. It's free floating, it's not engaged, it hasn't lightened. So cephalic is what we want. Breech, extremely healthy babies, but this baby most likely would be extremely hard to deliver vaginally. And this baby in the middle, not only is he breech, because you see his butt first, he's called frank breech because his feet are up, if that makes sense at all. Very, very hard to deliver. I've seen one breech baby delivered in all my years. I'm sure Christina saw more, but because I was on the NICU side, and it was a mistake. The nurse thought she was feeling its head, and lo and behold, it wasn't the head. It was its butt. and a doctor got very, very angry. But he somehow or another got the feet in alignment with the baby so he could bring it down straight and not the widest part coming out first. Breech babies it's a very high nurse delivery, and it's never the first choice. The cervix can clamp down on the baby's neck, so oxygen delivery can be a problem. They can be very hard to get out. Breech, in the United States at least, are always a scheduled C-section, or if you get in, they do the Leopold's maneuvers, or they're like, its heart rate is in a weird spot. They ultrasound it, they look at it, and like, oh, that weird spot's because it is breech. Then they'll come up there and do a C-section for her, on her, whichever way you want to look at it. Because in general, it's just not safe. Transverse is when it's going side to side. And these babies are all positioned in response to mom's spine, not the baby itself, but if you look at mom's spine, what direction is the baby laying in? So on the right, it's transverse as it's going side to side. This baby would have to be manipulated to be delivered vaginally. I've seen it go both ways. They slather some mineral oil, what is it, aversion, where they look at the baby with an ultrasound, they watch its cord, they gently, forcefully, try to grab the baby's head, its buttocks, move it down gently into a vertex position, which would be cephalic, so it would come out vaginally. If not, they can't move it, or if it keeps going back, she'll get herself a C-section, okay? And if you look at the placentas on all of these babies, they're all in the right place. You see one up on the fundus and two on the side of the uterus. Those are healthy looking, positionally wise placentas. So the only difference between any of these babies, they're all healthy, is the need for a C-section. And here is lie. So if you remember geography, lie is the direction of the equator. Remember, up and down is longitudes, right and left is latitude. If you can go back to your 5th grade, is it geometry? No. What was that we all took?
Geography.
If anyone remembers it, clearly I do not. You're looking at longitude up and down, and latitude is to the side, if that helps you. So that is in relation to the fetal lie. It's very similar, but a baby can be breech and still be fetal lie longitude, okay? Because what we're looking at is the direction that the baby is in relation to mom's spine. And if you look over there on the right, you're gonna see longitudinal. That's mom's spine. So longitudinal is when the baby is in alignment with mom's spine. It's up and down. It could be butt first, it could be head first, but the baby is in alignment with mom's spine. Oblique is when it has a bit of a twist. It is not definitely head down, but it's more of a shoulder, and it's got a little twist. Sometimes C-section, sometimes that baby could be delivered vaginally. It's a doctor call. Transverse, in relation to mom's spine, it's running side to side, which would be transverse. All these are healthy babies. They're gonna all do great. It's just a version of, do we try to move the baby? Do we do a C-section? You know, what is the plan? And there is always not one, so it's also up to mom, what they want to do. The middle one, gonna be hard to deliver. Any questions? Okay, oh, I can't see the top of this. Oh. It's harder on my laptop. Let's see here. Well, let's see if I can read it from my tiny writing here. I cannot. So the
That
nurse.
right corner, you might be able to do zoom in or zoom out in order to be able to see it.
Maybe, let's try. Oh, look at that, thank you. Okay, a nurse receives bedside report, yay, on a laboring client, that the fetus is a -2 station in transverse. The mother asks what this means. What do you explain to the mom is going on? Well, we've learned about all of these things since our lecture started, so let's talk about it. It means that the baby is about 2 centimeters below your hip bones and coming out butt first. Well, the 2 centimeter part is right.
Is the
But,
second,
do what?
is the second one?
It is the second one, yeah. 2 centimeters above your hip bone and lying sideways. So we look at it 2 centimeters above, -2, not engaged. And then lying sideways is it's transverse to your spine. Does that help? We get a little bit more into some of these soon, but definitely it is not below your hip bones because it's a -2. Cross that one out. 2 centimeters above your hip bones, yes, it will, and will be delivered soon. Not likely with a transverse baby, especially if it's -2. It's not even really truly engaged in the pelvis yet. It's still up. 2 centimeters below your hip bones and face up. Nope, -2 is always above the hip bones. So that's what questions would be phrased as. Where is this baby in relation to the pelvis, if that makes sense? And then the next one's another question. So this one is the hardest for me, and I'm going to tell you why. So fetal lie is, fetal attitude, the next one's like, fetal attitude. What is the position of the baby in relation to in a tucked position, which is flexion, or extension, which is stretching itself out? All right? Okay, so fetal attitude, vertex, and if the way that you can tell these if you can't palpate it is when mom's cervix is checked. You see across the bottom right there, it's what you feel when you stick in your fingers to check the cervix. What part of the baby am I feeling? Vertex is head down, all good. Military, that sounds weird, military. Do you see its little hands, how it's ready to fight? That is called military position, and the hand could actually be next to the baby's face, which is going to make it harder to deliver. Brow, if you look at the bottom, you're going to see the brow, the top of the forehead of the baby. So it's not in a very good tucked position, and it's deliverable. It's just going to take a lot more work. And full extension, do you see there on the right at the bottom when you see a face? I've seen this before, and you went in to check mom's cervix, and what happens? Somebody tell me what you think would happen.
Poke the baby in the eye.
You could, yes, it sucks your finger. Isn't that funny? They're like, oh my gosh, I just checked her and that baby is sucking my finger. I'm like, that's bad. But you can deliver like that. They can try to get the baby's head more in an alignment, but these babies could all deliver. This is just vaginally. This is just another thing that we look at to try to see how easy her delivery could be. When the face presents down there at the back, at the very bottom, it's called the mentum. I'll show you one in just a minute, which is a good, easy way to remember something. So fetal position, this is the hard part. The relationship of the presenting part of the fetus, either the sacrum, which is the butt, the mentum, which is the face, or the occiput, which is the back of the head, the pointy part in the back of your head, preferably occiput, because that's what we like, a nice tucked position, in reference to its directional position as it relates to one of the 4 quadrants of the maternal pelvis. So, broken down into 3 letters, okay? The first letter is, what side is it on? Is it the occiput on the right or the occiput on the left? And we're looking at mom's left. So it's not, if you look at mom straight ahead of you, that's not what we're looking for. We're looking for if mom was to say, look down and go, okay, so it's on the right or the left or the front or the back. It's how she would see it. So it's relation to mom's spine, not what you're looking at. So always look at it that way. The second letter reference is presenting part of the fetus, either the back of the head, the butt, sacrum, mentum, face, or scapula, SC. And scapula, do you remember how we were talking about some of the transverse babies and oblique lies where they're kind of twisted? That would be a scapula. It's just not in a very good position in mom's uterus. The third letter represents the anterior, front, posterior, back, or transverse part of the maternal pelvis. So here's a picture. This is mom's spine. If you see the sacrum, that's where her spine would be. And her right is on our left, and her left is on our right. Does that make sense? Left posterior, back, right posterior, back. Then you go through the transverse, and then the front of her right is the right anterior, and the left side is the left anterior, because this is all in relation to mom. So what we're looking at here is we're going to try to figure out what position this baby is in to see its chances of one, delivering vaginally, how hard it's going to be, and what part would be coming down first. Obviously, some of these around the bottom right, these are in your book, I think, are these are breech babies. Do you want me to tell you something? Someone say yes. Say yes.
Yes.
Yes, yes. I'll take you a deal because this is so hard. We really, in our school, what we look at is the baby breech? Yes. Is it transverse? The ones that we worry about the most of them on here are not nursing type things. The doctor will come out and tell us. What we worry about is where is OP? Right, occiput. Oh yeah, right, occiput transverse. You see the type right there where it says ROP. OP is what we're looking at. That baby is going to be delivered with its face up, and they're a lot harder to push out. It's a much more painful back labor is what that would be normally. Oh, she had back labor. The baby wasn't in a good position. So the main ones we worry about are OP, which is one at the top, and OA. Where is OA? Next row, you see where it says left occiput anterior, or the one next to it, left occiput transverse. These aren't so bad. In fact, we like left occiput anterior because that's the baby that's being delivered face down and makes the twist that we like it to make from those cardinal positions. So that's a deal I'll make with you. And mentum, see right there, right, mentum anterior, it's a face. So I'll make a deal with you that this is so hard for me to understand. If some of these, I can't tell the difference between what some of these are, you shouldn't have to either, because if you look at right occiput anterior and right occiput transverse, those are really close. Do you agree with me? Anyone?
Yes.
Yeah.
Me too. They're very specific, and Christina probably can do it, but I have rarely seen a nurse come out and go, well, that would maybe be left occiput transverse. Is it face down or is it face up? Because it's going to determine how its labor is and how hard the baby is going to be to push out. So I'm of the opinion that these are great knowledge to have, but please don't spend hours and hours and hours trying to understand what some of these are, okay? Just know that it can be it can be face down, face up, it could be breech, it could be, you'll see at the bottom, a mentum, that's its face. And they all affect how either does she need a C-section for a safe delivery, or is it just going to be a harder labor because the baby has to move in not the cardinal movements. Does that make sense? Take that as a yes.
Yeah.
Yes, okay. So I have another picture down here if you want to learn it. It's what you would feel upon checking a cervix and what position would this baby be in. And like we talked about at the very top, there's OP, occiput posterior, not good, hard to deliver because it can't tuck itself just right. At the very bottom, you see OA, coming down face down. It can go through the cardinal movements easy. The every darn fool and Enid eats eggs. It'll go right through those and hopefully will come out very easily. LOA and ROA should be about the same too, but some of these are just really hard and you only have so much time in nursing school. So touch on it, understand it to the best of your ability, but don't spend hours and hours trying the difference between it having a little twist or not, okay?
Excuse me, Wendy,
Yes.
you have a question in the chat. Which
Oh, yes.
position was most ideal again?
OA. If you look at this, you see the baby at the very bottom with the little A equals anterior, right between the two, the middle part of the sacrum. See how it's face down? That is ideal. It's going to go through those movements of every darn fool in Enid eats eggs easily because it's in the position to go through them. If it's OP and it's got a twist to it or face up, one, it's going to be a really hard labor, back labor, because the baby's head's mashing on the sacrum. Two, it can't tuck its head backwards to make the movements that it needs to. Does that make sense?
Thank you.
Okay, our goal is to do that so it can go through the cardinal movements. That's an easiest labor, which is what we're talking about. And we all saw this last week. These are ways that the physicians can help get the baby out, either pulling it into a better position to come out, or if the baby is in stress, we can sometimes put the suction cup on it and get it out faster so we can get it oxygen on our warmer and not from the placenta. I'm trying to think. Big babies, mom's having trouble pushing, she's tired. You're going to see suction cups used all the time. I promise. A third of you will probably see one used this week in clinical. The top is forceps. I am old enough to say I've only seen forceps put on the table one time, and they were not used. The doctors much prefer the suction cups. Here in the middle, if you look, I've only seen it happen once, so don't worry too much about it, but it can cause a brain bleed. Rare. I saw one. It was very sick and it was very bad, and I don't know how the baby fared, but all the blood from the baby had bled into its head. So when you tapped its head, it was like a little water bed because there's so much blood under the scalp that had leaked out from the suction cup. I'm pretty sure that doctor doesn't do OB anymore, is what I'm going to tell you, but be prepared to see them. They're usually very gentle. They come out. The very worst you're going to see is a bruise right where that suction cup was. If you see a baby that has a bruise there, that's exactly what they use with a suction cup. It can affect the baby's need for phototherapy later because of the bruising, but we can fix phototherapy. We can fix jaundice. We can't fix a baby that's inside of the vagina still not being oxygenated very well. Our goal is to get them out as fast as possible. So there's two kinds. One's firm, you'll see it on the left, and one is not firm. It's on the right. It's a doctor's choice. That's all I know is when someone says, go get the kiwi, Wendy, I bring them and I begin to throw them on tables for people. Where are we? Fetal monitoring. What are we looking at here? Remind me, why are we looking at fetal monitoring? External and internal. I think we're just looking at, I don't know why this slide is here, but it is, and we've already looked at this. This is fetal monitoring. You've got maybe was it the scalp probe? Oh my gosh, yes. Babies, we can monitor them. Remember on the outside with the fetal monitor that's next to mom, you'll see it put a little paper strip out that's also being read at the desk. So if something, you may think, oh my gosh, that nurse isn't paying any attention to that woman in there. Why not? She is. She's at the desk watching the fetal monitor strip that's coming in at the desk. That's also coming in at the mom's room. And that strip, the paper strip, don't throw it away. It goes in mom's chart in case there's ever any legal issues. The hospital still has the fetal strip if they need it. On the bottom, do you remember last week where we showed you that we had screwed a little electrode into the baby's head? You'll see it right there. Squish, it's just the two cords, screws into the baby's head. Baby starts crowning, coming out. The doctor will literally just cut that electrical thing going into the head. They'll just cut it off. I don't know, I'm like, you're gonna electrocute someone, but literally they just cut it with a pair of scissors and it's just fine. Sometimes it falls off on its own because it wasn't under there very good. If not, I'll take the baby as long as it's doing well, put it up on mom's chest, and you can just gently untwist it and it comes right off. If you see a baby in the nursery or going in and out of mom's room that has a little scratch, or it can get kind of big, not as big as a dime, but smaller than a dime, but bigger than a pencil eraser. It was a little bit hard to get it on, so they had to kind of scratch the baby's head as they were screwing it in. They couldn't get it in very well. If they're very severe, we just put some bacitracin on it and let it scab up and heal on its own. All right, so the last part that our class has listed is psyche. And one would think, well, this is a natural process. It's going to happen no matter what mom does. So why is it important? It is critically important. Mom's state of mind and feeling of control during her delivery experience is critical because, and this is one reason we have prenatal classes, because we don't want a mom coming in to have a baby that doesn't know any of the stuff we're going to do to her, with her, that she's asked for. She has no idea exactly what childbirth is, how the baby's going to come out. She's just scared. And that is not what we want. We want people educated. We want them knowing what we expect to happen, what would happen if something did not go well. My experience has often been that if you come in with an extensive birth plan, you get a C-section, not on purpose. It's just the gods that be do that, and I don't know why, but it does happen. I swear to it. But fear, tension, and pain, it's a vicious cycle that once it gets started, it's very hard to break. So we do not want fear. We don't want a woman coming in that is uneducated and non-prepared for what labor in a hospital is going to be like. If they're afraid, they're going to become tense and have tension. That tension is going to make the pain worse. The pain's going to get worse, and mom's going to be even more afraid because she doesn't know what we can do to help her manage her pain. So then the tension gets worse, and she doesn't dilate, and so her pain is worse. Does this make sense? It's a cycle, and it must be broken, and that is the main reason that we offer childbirth classes. The state of the mom's psyche is crucial in childbirth. It's marked by anxiety, fear, or fatigue. Anxiety in a laboring mom is different than someone wanting, say, their gallbladder taken out in the surgery area. It's pain, it's afraid, it's not knowing what's going to happen next. Why are they coming at me with their fingers? That hurts. Why don't you just stop doing that? Baby's come out, she's bleeding a lot, we're giving her injections, we're massaging her fundus, and it hurts, and she's yelling at us to hurt. An uneducated mom is much, much harder to have a good quality delivery. So we like our moms educated. Decreases the woman's ability to cope with labor pain. If you really hurt and you're screaming instead of bearing down and pushing, it's much harder to deliver the baby. So they keep screaming, they're not pushing, and it just gets worse because they're not focusing all that energy on pushing, they're focusing it on screaming, which of course is completely natural, but it makes it harder to expel the baby. Maternal catecholamines in your brain, they are secreted in response to anxiety, fear, and they can actually inhibit your uterus from contracting. So this is why you would hear a nurse at the desk, a mom comes in, wants to labor naturally, she's a 5, and she's been at a 5, and she's out of control, and it really hurts, and you'll hear a nurse say, she just needs to get an epidural. She's not saying that because she wants to break the mom's labor plan because she didn't want one. That's not why she's saying that. She's saying that because in all likelihood, if we can get this woman's pain under control somehow, her cervix will go ahead and completely dilate so she can have a vaginal delivery. There are no awards in childbirth. You are not a better mom if you do a delivery without an epidural than if you do. You're still a great mom and you have a healthy baby. Change your mind, don't change your mind. If you don't change your mind and you want one, that's okay too. We'll do our very, very best to help you. We can give you opiates up to probably about 7 or 8 centimeters. If we give it too late, it'll affect the baby's breathing. So once you've hit 8 centimeters, it's not going back. We can't get an epidural in you at this point, and we can't medicate you because it'll make your baby not breathe. So here we all are. So pressure on her back, whatever she asked for is helping her. An ice chip, pressure on her back, a birthing peanut, you'll see them, a birthing ball. If she doesn't have an epidural, she can change her position a whole lot more, or I would say better than someone who has one. So help her get into a comfortable position. But there is a point where we can't help you with your pain anymore. And the relaxation augments the natural process of labor. Again, anxiety and pain do not help labor and delivery at all. So this is after the baby's born, all sorts of circumstances. The one on the bottom left, I'm pretty sure she delivered either in a midwifery clinic or at home. Oklahoma City does have one midwifery clinic. I do believe there are maybe 3 or 4 midwives there. There's one in Tulsa also. So in this part of the country, we really don't utilize midwives very much. The few people I've known who went to school to be midwives, all but one does not practice. They all had to move out of state to do it. Tracy, our boss's wife, is a midwife in Tulsa. She drives back and forth. So it's not something you're going to see a lot of in our area. And we don't do midwifery schools. We all go to hospitals. So what you're going to see is the Western medical version of labor, which is a lot different than someone who is going through a midwife. Someone that has been through a traditional course of prenatal care from 1 month pregnant to 9 months pregnant and suddenly says, I want to deliver with the midwife. It doesn't work very well because the midwives have spent the last 8 to 9 months preparing that mom for a completely different version of a delivery than she would get in a hospital. Someone who has selected a midwife, they will not have external monitors on. They will not have a uterine monitor. There would be no fetal scalp monitor. The big one I'm thinking is pain. They're gonna get no pain control at home, and that's okay if they've been prepared. Breathing techniques. There's a whole host of things the midwives do to prepare that woman for a non-surgical medical delivery at home with no pain medicine. And if you've had a super healthy pregnancy, you've been to the midwife on their schedule, because it gets more frequent the closer you get, and everything has been completely normal. Your weight gain has been fine. You haven't lost too much weight. The baby isn't too big from what we can tell. They probably had an ultrasound to make sure the baby's in good condition. There's no fetal anomalies that could make delivery really bad for the baby. Her blood pressure has been completely normal on every single visit. She has had no signs of spilling protein in her urine. Everything has been perfect. The chances of her delivering safely with a midwife are great. Good midwives, if at some point during the pregnancy they see something that's an outlier, the blood pressure is trending, mom's blood pressure is getting higher, the baby's not growing at the rate we think it should be growing at, we've done an ultrasound and there's something not quite right, say with a part of the baby, she'll be transferred to the care of a physician and deliver in a hospital. Because we don't have everything that we need to fully resuscitate a mom or a baby in their home, like say a blood transfusion. We are not prepared for a baby to come out sick and mom to be bleeding and need to call an ambulance to come get mom to take her to the hospital is really bad. So women who want home birth, it's great. Be prepared, follow exactly what they say. Make sure you're going to a certified midwife who knows what to look like with your developing of your body, and the baby is developing, and you should be fine. So that's a totally different thing that we don't really talk about. What you're going to see in the hospital is nothing like what you're going to see with a bunch of women supporting a baby. In the middle, that's called skin to skin, also kangaroo care. You see it right there on the left too. I love this picture in the middle because it shows these are preemies. The little brother's bonding with them too. Is that not the most adorable thing ever? That he is bonding to those babies even when they're in the NICU. He has a responsibility and a role in helping keep them warm. And I love that picture. At the top right, there was a time not that long ago where babies were all kept in a nursery. I know you don't believe me, but it's true. They weren't locked up either. Anybody who wanted to would stroll right on in the front door of the OB unit. They would have it lined up just like that with all the babies, and you could look through a window and stare at the babies. And that is what made me become a NICU nurse, because I was fascinated by it. And you can't do it now. The model of keeping babies in the nursery and only taking them back out to mom's room for feedings and then back to the nursery, that's dead and long gone. Some of it's good. People need to bond with their babies, and it's excellent. The bad part, in my opinion, I'll just give you that, is that a woman can come in for an induction at say 6 o'clock. Let's say today's Monday. She could sign up last night at 6 a.m. to have some Cervidil or Cytotec placed in her her cervix to dilate it. And then we start her Pitocin to make the cervix start widening at say, 5 a.m. That woman got no sleep last night. She's going to get no sleep during the day because she's going to be in labor. And then we give her baby to take care of all night long. It sets you up for postpartum depression. I wish we had like a perfect model where as long as you want your baby, you keep it with you. If you want someone in the nursery to take your baby at night for the nursery, that will keep a really good eye on it and bring it back and forth for breastfeedings. I think that would be wonderful and ideal. There is a direct link between postpartum depression and maternal and dads for that matter too. It's not just mom, complete and total exhaustion, and it's definitely related. My experience has been lately that the nursery is not even allowed to take your baby at night officially. There's a sign inside mom's room that says, "We have no nursery. Your baby stays in your room 24/7. Congratulations." I think we need to have something to support our mamas. I do. So that's my opinion, but what you're going to probably see is you might see the babies being taken to the nursery for, say, blood tests, but they really will not be taken to the nursery so mom can get a break or dad can get a break because they're exhausted and they've been up all night. I'm of the opinion it's not ideal. There's gotta be a middle ground between we're gonna keep your baby away from you in the nursery, or we aren't gonna take your baby away at all and you're stuck with it 24/7, even though you've been up for 3 days straight. That's my opinion. C-section is what's going on here at the bottom. You'll see the baby is being placed skin to skin on mom in a C-section. If we do that, which we do, you need to stay right with that baby because mom has one arm holding the baby on the left. Her right has IV fluids going through it. Stay right there with that baby. Dad should hopefully be there, or mom's support person. Another mom, I don't care. Someone needs to be making sure that that baby is safe up against mom's skin so it doesn't roll off, because she is not in a bed in a very comfortable position at all. That's my bonding spiel. Culture is also critical when caring for moms. There are so many culture variations about what people, I will use the word expect, to have happen with their labor. There are cultures who do not want a man in the delivery room. They don't want a man placing an epidural. And that is their right, that is their culture, and we will do everything we possibly can to help them. There are cultures who, after delivery, mom isn't allowed to bathe for 30 days. I've helped a mom wash just her feet, so she didn't get in trouble with the other women in the room, because the belief is that if mom gets a chill from a shower, she'll get sick. She's also only allowed to drink warm liquids. So I show her family where the microwave is so they can warm up the liquids for her. If they come up on her tray and it's not as warm as they like it, they are free to go heat it up, or I'll do my best if I can to make it warm for her. It's one of those things, if it's not hurting anyone, do whatever you want. If your baby is stable and being well cared for, mom's bleeding's under control, I'm 100% on board for whatever we can do to make you and your family happy. But the line would stop for me, at least as long as the baby was doing well. If the baby's not well, I will sit down and we'll have a chat, because that's really all I care about is safety. So a culture gives her clues about how she should behave and react with labor, and how she should interact with her newborn. It's important for you as the provider to know the values and practices of many different cultures. You're going to encounter in OB care, and OB is probably the one area I can think that it's more important than anywhere else in the hospital. It's always emotional for every single person there, including the nurse. Good things, bad things, it's emotional. As we have told you every single semester, always be aware of what your feelings are about what's going on with your patient. You cannot provide culturally sensitive care to a client if you don't know what your own feelings about that culture are first. It is impossible to do. So if you encounter a situation, ask yourself, am I uncomfortable with this? And if the answer is yes, then educate yourself. Try to be more open. Don't just call in another nurse. Try to be more open and think about what's going on from your patient's point of view. Here's an extra P that it doesn't have, and it's birthing position. And I just threw this in because it's interesting. These are all birthing positions. What I will tell you is that if you're going to I should say it as like a slogan, if you're going to one of the metro hospitals and your mother has had an epidural and Pitocin, which is probably about 99%, she's going to deliver in the lithotomy position. Birthing chair, is that not absolutely amazing? And the pharaohs use them, and they would squat, which is amazing. The upper right is more of a birthing chair, and probably a midwifery clinic. The lithotomy position, let me find you a picture of it. I don't even have one. You know the position we had the mannequin in the other day, with its legs up, spread apart? That is the most common position that you will see babies delivered in. Christina has done this a lot more than me, so she's probably going to say she's seen it more. I have rarely seen someone not deliver in that birthing position. Once she has an epidural, her legs are not fully under her control, so it's not very easy to walk. In fact, I don't think you can. Getting on her hands and knees is very difficult unless there's something wrong with the baby and we need to get her in for a C-section, and then we manually flip her over. I think the only med that you guys have is Pitocin, AKA in a metro hospital. It's called vitamin P. If you hear, oh yeah, she's on, everybody and their dog's on Pitocin. When they augment, you come in labor, they're going to augment it with Pitocin to make it go faster, which isn't necessarily a bad thing. They will use it to induce labor once you've had your cervical area ripened. She's also giving a bolus right after delivery. You're going to see someone go over to the pump and reset it at 999. It's going to be going so fast, it's making that noise until she's gotten her Pitocin bolus, which will hopefully make it so she doesn't bleed too much after her placenta is out. Side effects are blood pressure and pulse changes in mom, hypertonicity of the uterus, which is one reason we always want to make sure if a mom is on Pitocin, her uterine contractions and her baby are being monitored at all time. If an external monitor, the belts across your abdomen aren't doing it, she needs an internal monitor. If you can't place an internal monitor, or for some reason she doesn't want one, the Pitocin needs to be stopped until you can ascertain how forceful are her contractions. Are they coming up back to back to back and the uterus is never really relaxing? How's the baby tolerating it? Baby's heart rate's dropping. She's having late decelerations. The baby is not tolerating labor very well, and you keep giving the Pitocin. I've seen one baby die that came into the hospital healthy, and it died in the hospital, and it was related to a ruptured uterus, which was related to a nurse, and the doctor was even in the building. She could not get the baby to trace and keep up with the uterus contractions externally. Mom had a doula, and mom and the doula flat refused any internal monitoring, but the nurse did not stop the Pitocin. She kept using it. And the uterus ruptured. Basically, it popped open. Imagine a C-section that's unplanned, and it just basically, you can't see it from the outside because it's all internal bleeding, but basically the uterus just kind of explodes would be the best word. And it's not in any straight pattern or anything. And by the time you get to the C-section area, because obviously something's horribly wrong, mom's sick, bleeding internally, baby has no pulse because the placenta is not working anymore. By the time you get her to the OR, oftentimes the baby has died. I was there when it happened one time, although she was being traced. Great labor nurse, caught it early, got her to the OR. Baby, they cut mom to try to do a C-section. Baby free floated right up in the abdomen, right up, because the uterus isn't protecting it any longer. Got it over to the warmer, put lines into, we were talking last week about the umbilical vein and how we can put tubes in there. So we started replacing its blood with saline immediately until we could get blood transfusions brought up. Baby lived. It was a miracle. I still am so happy that one worked out. But giving women Pitocin without monitoring their babies is a no-go. It's just not possible. It can make the uterus never relax. It can make it be hypertonicity. It's contracting too hard, and it can rupture, which can kill your baby. So you always, always, always want to have that woman on a monitor. But every single delivery that you're going to see in the hospital, she's going to be on Pitocin. It's an IV drip. Usually there's 2 bags, one main line of fluids and one pit, and they'll talk about it. And so they start at low, a low microgram, and then they start titrating it up higher until they get the labor pattern, the uterine contraction pattern, where it's safe for baby, safe for mom, and still dilating the cervix. Does that make sense? If you turn it up and the baby starts to not tolerate it, or the contractions won't stop, they're either going to turn it off or back off where it was before. They kind of have a standing order for that, so it doesn't really take a doctor call every time. But you're going to see lots of it. And we're almost done. So fetal compromise, we were just talking about this related to when would we call it on labor and mom needs a C-section. Fetal heart rate outside the normal range, which for a fetus, it's around 110 to 160. It depends on if the baby might be sleeping or not, but that's a really good range. I'm pretty sure this is from your book. Meconium stained greenish thick amniotic fluid. It's not a no-go with the vaginal delivery, but it is a big red flag that the baby has pooped in utero from stress and it could have breathed it in. What is making this baby stressed out? Not a absolutely no, but it's a sign that we really need to be careful. Cloudy, yellowish, or foul odor in the amniotic fluid, probably ruptured, didn't know it, and has an infection, amniotitis, I think is what it's called. Anyway, and it smells like rotten fish. I've been there once. It was horrible. And yes, she vaginally delivered, and the baby and her were already on antibiotics before we were outside the room. Baby did fine. Excessive frequency or duration of contractions. That's what we just talked about, the back-to-back contractions where the uterus isn't given the chance to relax and not re-infuse, but re-oxygenate, take a break. come back and start contracting again. It's just like back to back to back contractions, which there's never any relaxation to allow the baby to get some oxygen. In complete uterine retraction, that's the same, or I'm sorry, relaxation, the exact same thing. It's back to back contractions or long contractions with no breaks. Maternal hypertension, which it diverts blood away from the placenta, which means it cannot, mom can't get oxygen and neither can the baby. Maternal hypotension is mostly, I see, associated with the giving of an epidural, is starting the epidural. So a lot of times when women have their epidural started, they get like 1,000 milliliter fluid bolus through their IV to get their blood pressure up. So her blood pressure will not bottom out, because if her blood pressure drops, the baby's heart rate is going to drop as well. So we do our best to present that. Mom with a temp, they have their temperature assessed, I'd say every 30 minutes, just to make sure that we have this mom ruptured. She's close to having her baby. She could get an infection while she's ruptured because we're sticking our hands in there, and we're sterile, but it's still an unsterile area. So we really do watch her temp too. And there's more of problems with babies in your book. So I try to throw these at the back of lecture. It's not all the answers to the test. I will never say that, because it is not. But look through this, and if you look through these and you're like, I do not understand one word. What is this cardinal movement? You know, see at the bottom in yellow, cardinal movements. What on earth was she looking at? I don't remember any of those. Well, by golly, then if you look at this and you realize you don't know what they are, you probably need to go back and study that area more. Rupture of membranes, wrong. Oh, look, typical. Oh, 6. Oh, ferning, ways to test to see if it's urine or not. Strom, Arom, Prom, what on earth? I remember her talking about those. And if you don't look at this, you go, oh my gosh, I totally know that. You need to go back and do some more studying. Okay. So is this the answers? Absolutely not. But if you understand what is going on and the things I try to put at the end of class, it's a good indication that you are on the right track. Okay. Here's one. It's similar to the one that I had earlier, but it talks more about the stages of labor and the passenger, the passageways, all of that. And here's one. Is this another moment? Yep. These are areas of mom. We're going to go into this more in another class because this is labor. But these are changes that mom has made inside of her body as she is pregnant. And these are, on this one, of course, are all normal, which we'll keep going over. Today was just labor. But if you can look at this and go, oh my gosh, nutrition. Oh gosh, I totally know all of that. And you really do. If you look at that, okay, vagina. Well, estrogen, yes. It can be hypertrophic signs. Those are premonitory signs of pregnancy. If you can do well with this, it's a good sign that you're headed in the right direction. Okay. My suggestion is to always look at the objectives that are listed for the class. My thing is write them all out, and make sure you look them all up before class starts. It's a really great recipe for success. You're on your own. You can do this however you want to, but these are kind of like a going over type things that that I put on the end of most of my classes. Do you have any questions? Somebody must. That's a lot of information.
Oh, shoot.
Yes? Brooke, that was you. Do you have a question? No questions, people.
I have a question.
Yes.
So when I was doing the reading guide that was posted, there was a question in there, and it says, why must the fetal head and shoulders undergo rotation within the pelvis? Can you explain that a little bit?
Yes. Do you remember how we were talking about the cardinal movements?
Mm-hmm.
That is part of the cardinal movements, and that is how the baby comes out. It makes those twists so it's easier to deliver. If it doesn't make the movements, i.e. it's in a position that really doesn't make the movements very easy, it's going to be a much harder baby push out experience for mom. It can still be delivered vaginally, or she can push for hours and hours after being 10 centimeters and she still can't push the baby out. So she'll need a C-section after trying to get the baby out, which is a pain because you have someone dilated to 10 centimeters we've been trying to get a baby out. So she's probably got a laceration to her vagina and she's going to get a C-section. Those movements are what makes the baby come out. If it's not making those movements, it's going to be a very, very hard effort to deliver the baby. Let me show you. Let's go back up. I know where this is. This is what it's talking about. Do you remember?
Oh, okay, yeah.
That's what it's talking about. The every darn fool Anita eats eggs. If it is not engaged with the cervix face down like we like it, or twisted, or has the face facing forward, it's much, much harder to deliver than say. So this is ideal. That's perfect. If it's in, say, a position like this, get you there. That. The baby on the left can go through the cardinal movements. The one on the right, it's much harder because you see where its face is. The contractions are going to push that face further into the cervix, but it won't get it into position to be delivered easily. You're going to see a baby in this position come out with a really, if it's not a C-section, a really, really bruised face. The doctor can try to reposition the head with a suction cup also to try and pull it out still vaginally, but it's not going to be able to go through those cardinal movements we just looked at unless it's tucked in the right position. Does that make sense?
Sometimes we call,
Yes, I understand.
Go ahead, Christina.
sometimes we call position B face presentation.
Yes.
That's not ideal.
Yeah, mentum is what we covered in the class, but yes, it's a face. It's exactly what it is, because when you stick your fingers into checks, mom, you feel a face. It is hard to deliver a baby vaginally with a baby in that position. Lots and lots of pushing that can go on for hours and hours and hours. Suction cup, push, push, suction cup, and it's still, mom still can't get it out just because it's not in good alignment. So it's iffy if that baby could even deliver vaginally. Any other questions?
Instructor Morris, they are asking on our,
It's Professor Christina. I'm joking.
huh?
You can call me Wendy. I was joking. It didn't go good on the computer.
Oh.
I don't care.
They're asking if you will post this recorded lecture.
Okay, so here's the problem. It's not easy to do because it's so large. I can't get them to post. It's happened during COVID. I gave it a good go, but it doesn't like the length of a whole lecture being on Canvas. If someone can figure out how to do it, I am more than happy. A couple of students have permission. They've asked for permission. There's probably 6 of you guys that does have a copy of it that as their name came up, I clicked it and gave you guys permission to record it. So there are copies out there for sure with your classmates.
But you have the slides available, correct?
Oh gosh, yes, these slides. For some reason, Canvas loaded up the class that was a year ago for the semester. I reposted the class. It's in announcements. It's already there waiting for you.
Perfect.
I think too, when we exit off, if I'm remembering, if it's the same way when we did COVID, we did Zoom with COVID times back in 2020, when we ended the Zoom, it will ask the host, do you want to post to the cloud?
Oh.
So say yes, if it does, and then when the students, you guys should be able to go back into your Zoom in Canvas over to the far left, go into Zoom, and then you'll see previous recordings and recordings in the cloud. You should be able to click into that and it should pull that up. If it's the same way that Zoom was about 2-3 years ago.
I just know it did not like me trying to post the long ones. And there
Like in Uja or
yes,
yeah.
it was a pain in the butt, and then I'm like, I can't leave my house because I'm trapped here. I don't know what to do. But if it asked me about putting it to the cloud, you betcha. I did tell it to record when we started because it asked me, and I said, well, why, yes, I would like for you to do that.
I bet it is recording it in the cloud for us. And I think as long as you say yes when you X
can
it
do
up, I
that.
think it'll be fine.
Absolutely. Any other questions? I know for sure there's at least 5 or 6 of you with it too. No questions?
I had a question.
Yeah.
In the first semester, Stella did like Tuesday night tutoring, and it was just a Zoom, and it was optional, but we just kind of went on there and discussed things that we were struggling with. Do you guys offer anything like that this semester?
No,
Okay,
we do not.
okay,
First semester, we have a really high attrition rate. People that don't pass, the percentage is so high. I think that they are doing anything and everything they possibly can to get to help people pass, if that makes sense. We do have people that don't pass, but it's so much lower than first semester that our students, I don't know, if you start doing poorly in the class, I have a deal I'll make with you later. So if you don't do well on your first test, I'll make a deal with you, but let me know if you need help.
okay, that works.
It requires
Thank
a
you.
lot, it requires a lot of work on your part, but that said, I'm happy to help you. Sound good? Take that as a yes. So everybody ready?
Yes, sorry, I was muted.
You're good, just let me know if you don't do well in the first test, and you will expend a large amount of time, but you will work very hard too, but you should pass if you work really hard.
I'd rather work 24 hours a day than not pass, so that's
Me
good with
too, because you're just gonna be right back here again.
Yep.
So if you don't do well in the first test, let me know, okay? And that goes to everybody. Anybody
Yes,
have
ma'am.
questions? Clinicals, anybody have any questions about clinicals tomorrow and Wednesday?